Can someone confirm if they can hear me and see my screen as well?
Yes, sir.
Okay, great. Okay, let's get started. Hello, everyone. Good evening and welcome back. My name is Ashwin. I'm one of your TAs for the course Drug Delivery Principles and Engineering, and today is week 9 of this problem solving session that we're doing. We'll, as usual, take a look at previous year's week 9 questions as well as some of the this year's week 7 assignment questions. Okay, so let's get started. Okay, so the first question asks a non-compatible implant was used to deliver drugs in vivo. Which of the following activities will be triggered? So they say two options are correct here. Will the implant act as a source of drug without any hindrance? There may be higher chance of deposition fibrotic tissue onto it. A fibrous capsule can help it integrate with the body and enhance drug release characteristics. The extrinsic clotting pathway could be activated. The intrinsic clotting pathway could be activated. The drug will not elute out without a surface coating. Okay. Any guesses? So, and it's a non-compatible implant, meaning some reaction is going to happen in vivo. So definitely the first option is not correct, right? The drug will not act as a source of drug without any hindrance, because if that were the case, it would be a compatible implant. Since it's a non-compatible implant, there is something that will happen, and there is something negative that will happen that works against the drug and the implant. Okay, so first option might not be the correct option. There may be a higher chance of deposition fibrotic tissues onto it. Okay, this fibrotic tissue deposition happens because, uh, especially in cases of non-compatible implants which have not been surface modified, they get recognized by the immune system, and then there's this fibrotic tissue, dead tissue that's undergone fibrosis that gets deposited on there, and they're saying since it's non-compatible, there'll be a higher chance of this deposition that's occurring. Okay. Seems like a correct option, but let's go ahead. A fibrous capsule can help it integrate with the body and enhance drug release characteristics. That's not the case, right? If a fibrous capsule is forming and covering your implant uh, essentially is sort of useless, right? So it can't release any drugs outside, and that part of your body or whatever is cordoned off, so it's walled off, so it's not going to help it integrate with the body at all. In fact, it's going to not it's going to not facilitate this integration with the body. So and enhance drug release characteristics. That's not true. So if there's a fibrous capsule that's present, what happens is the drug finds it's much more harder for the drug to come out. So yeah, so it's quite the opposite of these two effects that they're talking about. So this is definitely not the correct option. The extrinsic clotting pathway could be activated. Okay. So, do you guys remember what the clotting pathway is? Hello. You guys can still hear me, right? Hello. Okay. Let me quickly stop and start again. Hello.
Yes, sir.
Yeah, you guys can hear me? Okay, great. Let me share my screen. Okay, you guys can see the screen.
Yes, sir, it's visible.
Okay, yeah. So we were talking about clotting pathways. So if you guys remember, the extrinsic clotting pathway is usually associated with tissue damage, right? So there are these receptors on cells that recognize tissue damage or cell damage, and then that triggers this clotting pathway to be activated. Whereas the intrinsic clotting pathway is mostly detected through surface contact. If there is a new surface or if there's a damaged surface, then the intrinsic clotting pathway is activated. Okay. So between these two, it seems more likely that the intrinsic clotting pathway could be activated, right? Because if you're putting an implant, uh, the clotting pathway is probably not because of tissue damage that you are causing, right? So the tissue damage would have already been there. But the intrinsic clotting pathway can get triggered because of surface contact, and if these cells sort of recognize this implant as something that's not belonging to the body, and uh, so on and so forth, then it will trigger this intrinsic clotting pathway. And since this implant is non-compatible, it will get recognized by the body, and that will in turn turn this cascade on of intrinsic clotting pathway. Okay. So that seems like a correct option. The drug will not elute out without a surface coating. Okay. Uh, it's not necessarily the case. The drug might still elute out, but at a much lower quantity than what you want the profile to be, right? So, for now, it seems like there may be a higher chance of deposition of fibrotic tissue onto it, and the intrinsic clotting pathway could be activated. So, yeah, those two are the correct options. Do you guys have any questions? You can stop and ask if you have any questions. Okay. Which of the following are professional antigen presenting cells of the immune system? Two options are correct here. Are T cells the antigen presenting cells, macrophages, dendritic cells, memory cells, fibroblasts, or B cells?
Sir, option B and C.
Okay, so macrophages and dendritic cells. Okay. Okay, yeah. So macrophages and dendritic cells are the professional antigen presenting cells. So B cells also do present antigens to an extent, especially to T cells, and they help in the formation of memory, but they are not the professional antigen presenting cells of the immune system. So the professional antigen presenting cells are the macrophages and dendritic cells. Okay, yeah. Okay. Let me see if I'm recording. Great. Okay, which of the following are uptake mechanisms at cellular levels? Two options are correct here. Is mitosis an uptake mechanism? Clathrin-mediated endocytosis, mitochondrial membrane depolarization, meiosis, cell migration, mitophagy, autophagy, or pinocytosis? Which do you guys think are
Sir,
cellular
B and H.
DNA? So, clathrin-mediated endocytosis and pinocytosis. Yeah, you're correct. The mitosis, meiosis, all these are cell division terms, right? So, yeah, okay. What are the implications of a foreign body response to an implant? Two options are corrected here. Correct here. Is it limited diffusion? Is it limited exchange of fluid? Is it increase in microvasculature? Is it increased coating of lipids? Is it increased exposure to dietary elements, or is it decreased coating of proteins? So they're saying a foreign body response has happened to an against an implant, and since this has happened, what are the implications? What could be the implications? Will there be a limited diffusion from like of whatever drug is inside the implant to go out? Will there be a limited exchange of fluid both ways so that cell migration also becomes hard? Is there increased microvasculature in the implant? Is there an increased coating of lipids? Is there an increased exposure to dietary elements? Or is there a decreased coating of proteins? It's okay if you don't get it correct. You can take a guess. We can talk about it. Okay, so like we previously discussed, so there will be limited diffusion that happens, right? So once this fibrosis deposition has happened, there will be limited diffusion that happens from the implant to the outside of the body. In a similar fashion, there will be a limited exchange of fluid also, right? So since this foreign body response has happened and now the implant is sort of baked or caked in this fibrotic tissue, uh, it's not going to be easy for diffusion or fluid exchange to happen either way. So options A and B are correct. Increase in microvasculature is not true. So if there is an increase in microvasculature, that would be ideal because it will permit cell colonization, right? But no, that doesn't happen. Increase in coating of lipids does not make sense. So there are no free floating lipids in the well, there are not so many free floating lipids in the body. And increased exposure to dietary elements again does not make sense unless uh, the implant is in uh, your stomach or something. But even in that case, if a foreign body response has happened, there's this coating that has formed around it. So it's not going to get increased exposure to anything. Decreased coating of proteins again does not make sense. So this fibrotic layer also often is adsorbed by proteins. So in fact, the opposite is true in most cases. Okay. What are the implications of a foreign body response to an implant? Uh, will it activate a classical pathway, the lectin pathway, the alternative pathway, secondary pathway, factor 8 dependent mediated pathway, or propyridine mediated pathway?
Sir, E and F, I guess.
Okay. Okay. Actually, it activates the alternative pathway. Yeah, fairly straightforward. So alternative pathway is where there's this again surface contact that's necessary, right, for the pathway to get activated. So alternative pathway is what gets activated. Okay. Okay. So we wish to generate an osteoconductive implant by coating it with fibronectin. For this purpose, an aqueous solution of fibronectin was prepared. Assuming the surface of the implant is positively charged, how should we change the pH of the solution so that a large amount of fibronectin is attached to the surface? They've given the isoelectric pH of the fibronectin PA, which is 5.75. So if you want more of this fibronectin to get attached to the surface, which the surface itself is positively charged, right? So if you want more fibronectin to attach to the surface with fibronectin, which has a pH of a PI of 5.75, what would you do? Would you reduce the pH? Would you increase the pH at 37 degrees? Would you increase the pH at 25 degrees, which is the storage temperature? Do you not change the pH at all, or do you make the pH exactly equal to the PI of fibronectin at 37? Do you make it less than the PI of fibronectin at 37, or do you reduce the pH to less than the PI of fibronectin at 25 degrees centigrade? What would you? So what happens at the isoelectric pH of a protein?
Some isoelectric point means the pH becomes zero at that point. That is means isoelectric pH.
Right. So, like the molecule would exist as a Zwitter ion, right? So it'll contain both. So for instance, if it's an amino acid, uh, the carboxyl group has a CO minus charge, and the NH2 group has an NH3 plus charge. So it'll exist as both plus and minus as a Zwitter ion, correct? Okay, yeah. So at an isoelectric point, a molecule, especially proteins and
Sir, option will be, sir, I guess option B.
option B. Okay, yeah. So as I was saying, so at an isoelectric pH, so the protein or the amino acid can exist as bitter ion with both positive and negative charge. Uh, so what you would want to do if you want to make the protein more negatively charged is increase the pH beyond this isoelectric pI. If you want it to be more positively charged, you'll reduce the pH. Yeah, so you will definitely, so in this case, since the surface is positively charged, you want the fibronectin to be negatively charged, right? So you would want to increase the pH beyond the pI of fibronectin. So you should make the pH greater than 5.75. Okay, now do you want to make it at 37 degrees centigrade or 25 degrees centigrade? Again, so 25 degrees centigrade, as I mentioned, is a storage temperature. So the reaction would most likely be happening at 37 degrees centigrade, right? So you would not do the reaction at a storage temperature. You would do the reaction at a different temperature. In most cases, usually between usually at an ambient temperature, but in this case they're saying that 25 is the storage temperature, so 37 degrees is what the reaction temperature is. So yeah, so making pH greater than 5.75 at 37 degrees Celsius is what you would want to do to sort of facilitate a large amount of fibronectin to attach to this positively charged surface. Okay. Which of the following is not a physiological event occurring during inflammation? Two options are correct here. Does vasodilation not increase with inflammation? Vasodilation of local vasculature? Uh, is there no increase in capillary permeability? Is there no influx of protein-rich fluid and cells at the site of inflammation? Is there no swelling? Is there no reduction in the
Option
temperature?
E and H.
Option? Sorry,
Sir,
could
E and H.
E and H. Okay. Yeah. So yeah, so there is vasodilation, right? So by definition, inflammation results in vasodilation, where there's this increased diameter of capillaries to facilitate more fluid and immune cells to travel to the location. And you want the immune cells to go out of your blood vessels as well. So there's this increase in capillary permeability as well. And yeah, so there's an influx of protein-rich fluid and cells at the site of inflammation, especially immune cells. True. As a result of which, there is swelling also, but there is no reduction in temperature of at the site of inflammation, right? So there is no need for any reduction in temperature, first of all, and there is increased blood flow to the site of inflammation. So there is no reduction in temperature. If anything, there will be a slight increase in the temperature, and there will be pain at the site of inflammation. So it's swollen, so it'll pain, and an influx of leukocytes and phagocytic cells into the tissue happens, right? So immune cells flood to the location, and migration of immune cells away from the site of inflammation is not true. So it's quite the opposite point of G, and that's exactly G is exactly what happens, and H is not what happens. So options E and H are the correct options. Okay. Which of the following is not an action of the complement system? Does it? So they're asking not an action. So does the complement system not trigger
Sir,
inflammation? Yeah.
sir, I
Yeah.
missed the previous question. Can you show me the answers?
Yeah.
Previous question.
Yeah. Yeah, so there is no reduction in temperature at the site of inflammation, and there is no migration of immune cells away from the site of inflammation. In fact, the migration happens towards the site of inflammation, and there is slight increase in the temperature.
Oh, thank you, sir.
Yeah. Okay. So, which of the following is not an action of the complement system? Does the complement system not trigger
Sir, option E
inflammation?
and H.
Option B and hello. I
Yes,
heard.
sir. So option B and H.
Okay, B and H. So you're saying complement system does not repel infiltration of leukocytes from the site of infection or inflammation, and it does not also protect foreign bodies or organisms from degradation. Okay. So does anyone else have any other uh, alternative suggestions? Okay, yeah. So in fact, they do quite the opposite, right? So the complement system, once it's activated, it will attract infiltration of leukocytes to the site of infection or inflammation for this complement system resolution to happen. And obviously, it will not protect foreign objects or organisms, especially since it's being activated by foreign objects. Some of the pathways are being activated by the foreign objects or organisms, right? So Yeah, so those two are the correct options. Okay, which of the following proteins is not related to the complement pathway? Two options are correct here. C3, C5, propyridine, factor D, factor H, C1, P53, and P10. Any guesses?
So option G and H answer.
Okay. Yeah, so wow. Okay, so G is also the correct answer. So GP53 is a tumor suppressor gene, right? So it's mostly involved in cell cycle regulation and tumor control. So P53 and P10 are the answers. All the other proteins are involved in the complement pathway, one way or the other. And do you guys know where the all the complement pathway activations converge at which protein?
C3 convertase.
Yeah. Okay. Okay. Which of the following cells are the first to reach the site of inflammation? Platelets, neutrophils, monocytes, T cells, B cells, basophils. So essentially, they're asking which of the following immune cells are the most mobile or motile, which can travel faster and reach
So
the site.
option B, I guess.
Option
So B.
B, neutrophils. Okay. Yeah, so neutrophils are the first cells that reach the site of inflammation in any immune response because of their small size and uh, uh, yeah, and their ubiquity in the body as well. So they are present all across the body without, except for brain, without question, and they can reach the site of inflammation very fast. Okay, a few other general questions that we've come up with just to give you guys a better understanding. So, okay, so local cytokine release triggers the following order of events. Okay, so does vasodilation come first, followed by influx of leukocytes and phagocytes, followed by increase in capillary permeability, followed by edema, followed by healing? Or does vasodilation come first, followed by increase in capillary permeability and then influx of leukocytes and phagocytes, healing and edema? Or does edema come first, followed by increase in capillary permeability, followed by vasodilation, followed by influx of leukocytes and phagocytes and healing? Or does edema come first, followed by vasodilation, followed by increase in capillary permeability, influx of leukocytes and phagocytes, and then healing? Uh, or does vasodilation come first, increase in capillary permeability, influx of protein-rich fluids and cells, edema, influx of leukocytes and phagocytes, and then healing? Or does vasodilation come first, increase in capillary permeability, and then increase of leukocytes and phagocytes, and then influx of protein-rich fluid and cells, and then edema and healing? Okay, so basically they're asking us the order in which an inflammation response takes place in the body. Okay, so which of the two do you guys think comes first, vasodilation or edema? Edema is
So vasodilation
swell.
come first.
Okay, yeah. So edema is swelling. So for swelling to happen, there needs to be vasodilation and this influx of things that are coming into the tissue, right? So vasodilation should happen first. So that rules out option C and D. Okay. So next we are sort of looking at does increase in capillary permeability come first or does influx of leukocytes and phagocytes come first?
So increase in capillary permeability after that comes. Then
Right.
influx of protein rich blood cells.
Right. So without the increase in
After that,
capillary
healing
permeability,
happens.
the leukocytes and phagocytes will not be able to come out of your blood vessels, right? So there needs to be an increase in capillary permeability, and only then influx of leukocytes and phagocytes can happen. So that rules out option A, C, and D. Okay. Now we are left with B, E, and F. Okay. So after increase in capillary permeability, is there an influx of leukocytes and phagocytes, or is there an influx of protein-rich fluids and cells?
So influx of protein rich fluid and cells occurs. Then
Yeah,
it leads to edema.
right. Yeah, yeah. So essentially, as soon as the capillary permeability increases, the fluid whatever is present in your blood vessel, right? So the fluid immediately rushes out. So that's protein. That's the protein-rich fluid they're talking about. And then there are these cells also, small immune cells like neutrophils and so on and so forth that also start to ooze out. So remember, neutrophils are the first ones to arrive at any immune emergency locations. So yeah, so that happens first, which I guess leaves us with one correct option E, which will then lead to edema, and then there's this in or swelling, and then there's this influx of leukocytes and phagocytes, and then healing happens, right? So yeah, that's the correct answer. Okay. Granuloma formation occurs when complement system is activated, inflammation is triggered, an intracellular pathogen is not able to be completely eliminated, cytokine storm unfolds, an extracellular pathogen is not able to be completely eliminated, neutrophils undergo extravasation, adaptive immune response kicks in. Do you guys know what granuloma is? Okay, so granuloma
Sir,
is,
basically occurs after inflammation only. Means I think it will be option B, sir.
okay. Okay, so granuloma is most often observed in tuberculosis, right? So tuberculosis, to briefly explain what happens, this Mycobacterium tuberculosis, the bacteria, it will enter the lung, it will get engulfed by the macrophage, right? So macrophage will eat it up, but the problem is the bacteria is able to survive in the extremely low pHs of macrophages lysosomes. So the macrophage is not able to kill it off. If the macrophage is not able to kill it off, it will send a distress signal to, so it will display a distress signal. As a result of which, other immune cells can sort of read this distress signal and then sort of form a wall around this infected macrophage, isolating it from the body. So that's how a granuloma forms. So for that to happen, the macrophage first needs to engulf the bacteria. So the pathogen needs to be intracellular, and it should also not die. So if it's die, there's this resolution of infection that happens. But if it doesn't die, only then the other immune cells of your body will come and nicely form a wall around this infected macrophage, not letting it access your body, the rest of your body, so that even if the pathogen comes out, it's isolated from your body. So that's the idea of granuloma. Okay. So inflammation usually does not need not occur. So in case of TB, like there's not much inflammation that occurs inside your lungs. So granuloma does not depend on inflammation. So it most likely occurs when an intracellular pathogen is not able to be completely eliminated by your immune system. Okay. Which of the following are not pathways associated with the activation of complement system? Uh, okay. So, is it the
Second is
sorry?
so option C and option A, sir.
Option F. Okay. Yeah. So the classical pathway, extrinsic pathway, alternate pathway, lectin mediated pathway, all these are part of the complement activation system, right? We don't have a pectin mediated pathway, and clonal selection is something that happens during T cell maturation. So, yeah. Okay. Yeah. So the extrinsic pathway is the correct option, but for some reason it's highlighted, but ignore that. Yeah, so pectin mediated pathway and the clonal selection pathway are the correct options. Okay. An implant is observed to be causing blood clot formation at the site of implant. What compound would you coat the implant with to prevent clot formation? Would you coat the implant with VEGF, tissue plasminogen activator, PEG, urokinase, PDGF, thrombin, or factor VIII? Any guesses? Okay, you do not want blood clot formation to occur, right? So that will immediately root out factor VIII and thrombin because they are heavily involved in the initiation of blood clot formation. So those might not be the correct options, which leaves us with VEGF, TPA, PEG, and urokinase. So PEG is not something that's known to prevent blood clot activation, blood clot formation. So that will rule out PEG as well. VEGF is involved with angiogenesis or formation of new blood vessels, right? So if you include VEGF, it will form new blood vessels, and there's more blood that's directed to the implant, and that will cause more blood to clot. So you would not want to uh, include VEGF as well. And PDG, platelet-derived growth factor, also promotes blood clot formation, platelet addition, right? So you would not want to involve that as well. So for if you would know, so tissue plasminogen activator and urokinase are both involved in prevention of blood clot formation from occurring. So you would want to give those two. So and tissue plasminogen activator, I think, is sometimes given in clinics as well to resolve blood clot formations. Okay. Blood clotting consists of the following three basic phases: inflammation, vasodilation, coagulation; complement activation, platelet aggression, cohesion;
Option E.
platelet aggression, constriction of blood vessels, and coagulation is what you're saying. Okay, so it's definitely not antigen presenting cell T cell activation. So there's nothing, the immune system did not get activated there. Constriction of vessels, platelet aggregation and coagulation, or platelet aggression, constriction of vessels and coagulation, and cytokine release in cell infiltration and coagulation. Again, cytokines need not be released, right? So, uh, uh, yeah, there's no immune system that's involved with blood clotting. So inflammation, complement activation, APCT cell activation, cytokine release, all this need not happen. So what happens as soon as you get blood? Uh, so blood clotting usually happens when you have a leakage in your blood tissue, right? So if you have a leakage, the first thing that needs to happen is the constriction of the blood vessels or vasorestriction. So vasodilation is the expansion of blood vessels, and vasorestriction is the constriction of blood vessels, right? So you'd want less blood to flow out of the leakage. So as soon as the leakage happens, there's this constriction of blood vessels that happens, and then and as this keeps happening, platelets start to migrate to the site of leakage, and they start to aggregate, and then coagulation happens. Okay. Okay, so with that, let's look briefly at the this year's week 7 assignment questions. Uh, yeah, which of the following is not a parenteral route of drug administration? Okay, so parenteral route is other than enteral route, or anything that's not associated with your digestive system, right? So they're asking which of the following is not a parenteral route of drug administration. So which of the following is an
Option
enteral? Option D and
F.
F. Okay, okay.
Yes, sir. Oral and nasal.
D and G.
Okay, DNG. Okay, so nasal route. Why do you think it's not parenteral? So nasal route of administration will directly give access to your lungs, right? So it'll give access to your lungs, your respiratory system, essentially. So and in some cases, brain as well. So it will bypass the blood-brain barrier and so on and so forth. But yeah, so mostly nasal gives access to respiratory system and central nervous system. It does not go to the digestive system. So you for it, parenteral means it's not going to the digestive system. For something that's not parenteral, it has to go to the digestive system, right? So oral and rectal are the two modes of drug administration that go into the digestive system. So those two are the correct options. Okay. What are the two most important sites for drug elimination? Is it spleen,
Option D. Kidney and liver.
kidney, and liver? Yeah. Kidney and liver are the most predominant sites of where drug elimination happens. So liver can metabolize drugs and kidney can filter drugs. Okay. Which of the following routes of administration has the least bioavailability for an acid labile drug? Is it oral, intravenous, subdermal, interdermal, or interperitoneal? So they have an acid labile drug, meaning that drug will get degraded in the presence of an acid. And they're asking which of the following routes of administration will therefore have the least bioavailability. Any clues?
Sir, option A.
Yeah.
Yes.
So oral, right? So if you give the drug orally, it will go into your stomach where there's acid, so the pH is less, uh, quite acidic. So the drug will degrade. So it will not have very high bioavailability. Okay. Which of the following mechanisms are not commonly used for permeation enhancement in transdermal delivery system? Is it iontophoresis, electrophoresis, surgery, ultrasound? Phot-
Option E.
Okay, so I haven't labeled the options. A, B, C, D, E. So you're saying photomechanical energy.
Yes,
Okay,
sir.
okay,
Surgery.
okay. Surgery. Okay. Use of chemical enhancers like DMO,
Option
DMSO.
C.
Surgery. Okay. Yeah. So photomechanical energy is in fact used to sort of increase the permeation enhancement. So what they do is they blast uh, high intensity light onto your skin to disrupt the barriers, so that there's this increased permeation that happens. But surgery, if you're doing surgery to transdermal, is basically just on the top of the skin, right? So if you're doing you can't do surgery on top of the skin to increase anything, right? So if you're doing surgery, then that's not transdermal anymore. So you can't increase the permeation of a drug through transdermal delivery by doing surgery. Okay. What kind of drug is not a good candidate for transdermal delivery? Pick two options. Low partition coefficient, high partition coefficient, low molecular weight, high molecular weight.
Option A and D,
Sir,
sir.
option A and D probably.
Yeah. Okay. Yeah. So fairly straightforward. You can't deliver high molecular weight drugs through transdermal delivery, usually greater than 1000 kilodaltons, and you can't deliver low partition coefficient drugs as well because they will not pass through your layer of skin cells, and then there's this layer of adipose tissue that's also present, right? So they will not pass through there. Okay. Okay, so this question I guess we discussed briefly last week as well. So I've talked to Rachit as well. So he's also of the opinion that pHs greater than 11 and 8 are the correct options. I guess someone was raising a doubt, so I don't know if you've raised the doubt in forum. If not, please do raise a doubt in the forum, and uh, people will get back to you. But yeah, the question reads: enteric coatings are likely to release drugs at what pHs? So usually enteric coatings are coatings that will get slowly degraded by acids. So that if you have this coating on top of your drug delivery system, the drug can safely pass through the your stomach acid and then eventually reach a high enough pH for the drug to come out. Right. So that's what an entry coating is. And based on that, they're asking us to pick two correct options where the drug would most likely release. So it would definitely not release at acidic pHs. If anything, it will release at neutral or basic pHs. So pH greater than 11 and pH greater than 8 are the correct options. Okay. The first barrier that is encountered with option B, stratum corneum. Yeah, so straightforward. Stratum corneum is the most outermost layer of your skin. So yeah, it's the first barrier that's encountered with transdermal delivery. Okay. The major problem of transdermal drug delivery route is pick two choices. The chances of allergy are minimal. Small dose administration is only possible. Drugs with molecular weight less than 1000 daltons cannot be given. Drugs with molecular weight greater than 1000 daltons cannot be given. There is control over delivery of drugs, or there is reduced system toxicity. So they're asking us to pick major problems, right? So most of this seem as pros. So reduced systemic toxicity would not be a major problem. Control over
Option
delivery.
B and D, sir.
Yeah. Okay.
Option B and D.
Yeah, small dose administration is only possible, and drugs that are larger than 1000 daltons cannot be given. Correct. Okay. Which one statement is false for bioadhesives? They're designed to slow formulation transit time. They can form bonds such as hydrogen bonding and van der Waals bonds. Uh, they can chemically chemically bonded bioadhesives are most highly recommended. Adhesives can also depend on physical entanglement of polymer with mucus.
Option C.
Option C, right? So you don't want chemically bonded bonding
Option
by
C.
yeah. So you don't want chemically bonding bioadhesives because chemical bonds are much more stronger and much more uh, quote unquote permanent compared to physical bonds, which can easily come off. And it'll also change the surface chemistry of your cells as well. So you would not want chemically bonding bioadhesives. Okay. Which one of these is an advantage of oral administration? Is it that unconscious patients cannot take the dose? Is it low solubility? Drugs cannot be administered. Drugs with low permeability cannot be administered. Degradation by GI enzymes of flora. Ease of administration. Food interactions.
E.
First met volume. Yeah, yeah. Most of these are so they sort of look like disadvantages of oral administration, right? So they're asking for an advantage. So one of the biggest advantage of oral administration is its ease of administration. You just pop a pill and drink some water and it's done. So yeah, that's the correct option. Okay, so I guess we are at the end of the class now. Do you guys?
Hello.
y-
Hello, sir.
Yeah,
Hello.
yeah. I can
Sir, I
hear.
have some internet issues over here, so I was unable to see all the options. Can you share me the link for the recording or the YouTube link, sir?
Yeah. I can show you the YouTube link, and there is also a link for PowerPoint slides. I'll share that also.
Okay, so thank you. Then later at night I will see them.
Okay, no problem. You guys have any other questions or
Or
general?
in week 8 assignment,
Okay,
question number 6.
week 8, question number 6. Let me share this link first. That's the YouTube link. Okay, let me open up week 8. Mm, week 8, question number 6.
Yes, sir.
Where will particles of size 10 micron mainly deposit after dry powder inhalation, right? Is that the question?
Sir, why the yes, sir? Why nose will not be an option?
Okay, so right. Okay. Is the deadline over for this assignment?
Yes, sir.
Okay. So the correct options are mouth and throat and large airways, right?
Yes, sir.
Correct. So what usually happens? So what usually people do generally in clinics for dry powder inhalation is you can't give dry powder, like generally it's not preferred that you give dry powder inhalation through the nose. This is because so you will not have enough force to push the dry powder into the lungs. So people put these dry powders in inhalers. So if you guys have seen this asthma inhalers and all, uh, bronchitis inhalers and all, they have dry powder formulations. So inhalers are what are used generally to deliver these dry powder inhalation formulations. So if people use inhalers, then most likely it's going to get deposited in mouth and throat and large areas because of the size, right? So that's one. And also, so nose it might be a little challenging because so for deposition to happen in the nose, the 10 micron particle has to be respirated out, uh, which is a little so 10 micron particle being respirated out is not trivial. So what usually happens is as a respiration happens outside, so it'll still get deposited on the walls of your airways and walls of your bronchiole and so on and so forth. But yeah, so it's not generally nose because nose is so people generally give wet formulations through the nose, not dry powder formulations. Does
Okay,
it?
sir. Thank you.
Yeah. Yeah, so you can't really give dry powder formulations through the nose because what happens is the airways in the nose are quite small, right? Like there is a lot of constriction that happens, and there's a lot of mucus that's present in the nose. So as you give these dry powders, they might start to coagulate and sort of coagulate together and block the nose airway. So that'll be detrimental to the patient. So usually they're given through a much larger route of access, which is mouth through inhalers.
Okay.
Yeah.
Sir,
Any
can you
other?
kindly show the first five questions that you discussed today?
Yeah,
Actually,
I'll
I missed the
yeah, it's
question.
it's okay. I'll share I've shared the YouTube link, so I'll upload the video there. But I'll also share the slides as well. So I'll send you the link for the slides as well. So you can go through the slides, and if you have any doubts, you can always reach out.
Okay, sir.
Yeah.
Sir, this
Thank
video
you.
will be downloaded how soon?
I'll
This
try to
recording?
upload it by tomorrow. By tomorrow evening, it should be up.
Okay, sir. Thank you.
Yeah. Any other questions? Okay. If not, let me just share the link for this PPT as well. So there are other PPTs also, like whatever we've looked at previously, also it's present there. So if you guys have any, if you guys want to go back and refer, you can. Okay. Can one of you confirm if you can open this?
Yes, sir. It is okay.
Okay, great. Thank you. Okay, okay then. I'll see you guys next week. Thank you for joining and have a good week ahead.
Sir, is today's week 8.
Today is week 9.
Sir, today's this numbers at week 8 or week 7? Today's slides.
Today's slides I still haven't uploaded, so I'll upload it right now.
Okay.
You will be able to access. In fact, let me just do it right now, and you can check back after 1 or 2 minutes, and you should be able to see that.
Okay, sir. Thank you.
Great.
Thank you, sir.
Okay. See you guys. Yeah, I've uploaded the slide, so it should be there. Week 9. Okay. See you guys.